Good afternoon, everyone. Today, I will cover three components. First component is an introduction to service with Care and Compassion Initiative, SCCI. So SCCI is a package for non-communicable diseases that are delivered through primary healthcare centers. So it started as a pilot project in 2010, and then over the years, there was a gradual expansion. And as of now, it is well integrated across all levels of hospitals. This includes the primary healthcare centers, the district centers, district hospitals, and the referral centers. Now, you may see the program being well implemented in some of the hospitals, while in some of other hospitals, it is still requiring some kind of integration. That is because it's at different levels of adoption. Now, there are three primary implementing partners of this program. It's led by the LSRD, Lifestyle Related Disease Program at the Ministry of Health. At the ground level, it is the primary healthcare centers or the hospitals that implement the project. And from time to time, we have a lot of flux of health staff getting transferred from one center to the other. Some are leaving, there are new people joining in. So this will keep on happening. So it means that the university will have to be involved in providing training to such staff from time to time. The core components of SCCI training package, which are summarized as 7R and 3C. The main focus, one of the focus of this program is to provide brief intervention. It's a very systematic package for alcohol and tobacco cessation. Then healthy diet and lifestyle education. And for the clinical component, we have the cardiovascular risk assessment. First part is doing the assessment. Second part is providing the appropriate intervention. The second major job where I was primarily involved is teaching on the protocol-based management for 4 major diseases. So we call it the big 4: hypertension, diabetes, stroke, and chronic respiratory diseases. Now, for some new medical officers, you may never have heard the term as chronic respiratory disease. Why? Because we know diseases by their names like asthma, COPD, bronchiectasis. But as of now, in Bhutan, we still use the term CRD. And the primary reason is that we are unable to, we don't have the capacity to really identify it as asthma, COPD, and then we lack the appropriate diagnostic facilities. Now, after we have provided all these trainings, now after the medical officer or the health assistant who has received the training will have to go back to his primary center and then provide what is called as peer coaching, which means you teach your friends. We provide you all the slides, you teach your friends, and then try to inculcate or integrate the SCCI activities in your center. And at the end, now the first part is doing the work, and at the end, there's always reporting and monitoring. For this, we have what is called as the HCD dashboard, which is an online reporting system. And then this will tell you how many patients you have screened, how many are under control, whether the patients have come back for follow-up. So there are many performance indicators that will be derived out of this HCD dashboard. Now, why is SCCI an important initiative, and then why are we spending a lot of time on it? This is because SCCI envisions one complete continuum of care. This means that we focus on prevention. First part is this NCD prevention, where we target the modifiable risk factors. We intervene on alcohol and tobacco cessation, and whoever has this, whenever there are opportunities, we do screening for NCD, and we are focused on providing education and advocacy. So this part is on the prevention. Now, during the screening processes, there will be screen positive and screen negative. If it is screen negative, then you rescreen it from time to time, periodically. If someone is screen positive for hypertension or diagnosis, then you put them on what is called as protocol-based treatment. This would mean that if it's a protocol, it usually comes in the form of a 1 page, which means it's very easy for people to follow. The second thing is that everyone follows the same protocol. So there's this standardization. This means that the protocol is being implemented in all 20 districts. This means that whether the patient is being initiated on hypertension or diabetes care at a primary healthcare center or at the National Referral Center, the starting point or the standard of care should be same. And through this protocol, then you'll be able to find how to monitor what are the targets, how frequent to call the patient. And then in addition to that, there is what is called as a CVD assessment. And then based on the assessment, you'll have to provide the appropriate intervention. Now, if at the end, if all our prevention and treatment have failed, and then if there will always be some percentage of patients who will require palliative care. So palliative care would require not in this SCCI program, we have focus at providing homebound visits and palliative care for various conditions. Now, this slide is the summary of the SCCI program, how we implement it. So I'll take a little bit more time to explain what each of these means. So we have what is called a 7R and 3C. So there are 10 principles involved. First one is that for you to provide in your hospital, for you to provide NCD-related care, you need a team. So that team would obviously mean that as a clinician, you won't be able to provide the complete care. So the robust team in our hospital or in every hospital should begin from inclusion of the team or reception team. So who will direct the patient to the NCD clinic or place where to measure the blood pressure, from where to get the medicine. You will have the laboratory person who will do the testing. You will have, if you have NCD clinic, one HA or nurse in the NCD clinic, you'll have the clinician who will review all the BP recordings or the blood tests and then to optimize the treatment. And you will require your pharmacist who will make sure that the appropriate medicines are given. And if the patient is supposed to come for a 1 month follow-up or a 2 month follow-up, and then if the patient doesn't turn up, because you are looking after only a finite number of patients, like on the Galliford or our hospital, we have around 500 patients. And if 10 of them misses the visit, you can call the patients and send them reminders saying that it's time for your review, and then you need to call them and then provide the medications. Majority of patients with diabetes and hypertension for every visit, do not actually require a clinician to intervene, spend a lot of time. Usually, most of them are under control, and then you'll have to provide refill. But make sure that during the refill process, if you need to adjust things, you do it, but make sure that the patient gets their refill of medications. The other important intervention or principles of SCCI is what is called as responsive referral. For example, if there's a patient with diabetes and then the sugar is not getting under control in your center, and if you would like to send it to a tertiary care center or get it reviewed by a medical specialist. Now, what you can do is that through your NCT focal, you can link it up with the NCT focal person of the respective referral hospital, and then send the patient. And then when the patient receives here, they will be channeled through the NCT clinic pathway, and then you will be able to direct the patient toward the appropriate clinician. The other ones are for the homebound care, or if a person with hypertension for various reasons, if they are, for example, like monks who are under monks or a hermit staying inside their closed compartment for a long period of time, you can go and provide reach out services or for palliative care. In addition, as a hospital administrator or as a pharmacist or in charge of your drugstore, you should be able to keep all the medications you should be able to have adequate number of that supply that's available in your hospital, because one of the main reasons why people fall out of your care is because this time you give one medication and next month when the patient comes, you say that you don't have it and you make the patients buy them. And this is one area where we have a lot of attrition of patients from care. So you should make sure that you should count the number of patients, how many are expected, and then make sure that you have a reliable supply of medications. There are many ways of getting a reliable supply. You ask from the central store, you make a timely indent. There are so many ways of doing it. And the final part of the R component is that there is what is called as real-time mentoring and supportive supervision. For example, at the bigger hospitals in every district or the district hospitals, it is their responsibility to monitor how the SCCI programs are being implemented in smaller hospitals or primary healthcare centers. And if there are lapses or if there are difficulties in the implementation of the program, it's the responsibility of the bigger centers to provide help. Now coming to the 3C components, the care should be coordinated, which means that in your own hospital, the NCT team, SCCI team has to work in close coordination. So in our hospital, we have a WhatsApp group and then we coordinate. For example, now to direct the patients here, if there's, for example, a lot of patient turnout and if you need more help, so this is how we coordinate. It has to be comprehensive, and then as long as you follow all the key principles of SCCI, your service, if you are able to deliver all the services, you can count it as a comprehensive set of service. And then this has to be the implementation, the whole process of SCCI has to be a continuous process where and then patient has to be this means that we focus on prevention, we focus on treatment, and then if both of them fails, we link the patient to a continuum of supportive care at the end. At the end of whatever you are doing with the SSI program, as a clinician, you're worried about single individual person. For example, this patient initially had this BP on the higher side, over subsequent months had a BP on the low, BP under control. So this means that as a clinician, you're looking at one patient. But from the programmatic point of view, which your NCT focal person is doing, is at the end of it, at the end of every quarter or from cycle to cycle, we look at what is called as control or uncontrolled rate. So this picture is the NCT dashboard. And for a clinician, it is individual data, but for the program, we have so many performance measures that will be derived out of this. So this means that if you don't recall the patient and if the patient misses it, then the patient might be classified as uncontrolled, or that's a part of you have failed on the recall. Now, if as a clinician, you have never read the BP and then you have just done proxy refill for a couple of months, then this might also lead to your uncontrolled rate. So there are many parameters that will affect your performance measures. And as of now, these performance measures are looked at it from a very kind of a formative way that where we're looking at from a very linear way as to where to identify areas where to improve and where to share our experiences. However, we never know that in the coming years, this might become one of the performance indicators of your hospital, and then you might be assessed based on how good a control or your performance might be based on your performance evaluation might be based on the indicators derived from this. Overall, SCCI is not for it's for every one of us, and then it is in Bhutan we have a very close knit society, and then from a SCCI is for all people, and then through this we are trying to standardize the level of care so that whether young or old, whether it's your family member or a member of your community, we are trying to provide the best of the care within whatever we have at the moment in our health system.